this chapter or this unit or whatever should be kind of all around mental health, but, and I have to admit, I had some slides that had some, that maybe I'm getting confused with oral med, but I thought I had some PowerPoints that had some slides about, like anxious patients and patients with maybe depression, or I thought I had some slides for this course, but I couldn't find them. I knew that I had the substance misuse and the eating disorders. And really there's no time for a third PowerPoint anyways at the moment, so it's fine. But there's a new edition of Darby and Walsh that'll be out in a couple of years, like a year and a half or 2 years. And I wrote the mental health chapter. So that's, I know, I've never done that before. So this will be revamped, but I just put this thing here. You guys have probably seen it for a while. And because in the chapter, it talks about dental hygiene burnout, which is actually, it's not just about treating patients with mental health, it's about protecting your own mental health. And so it's a really good chapter. I mean, not good, like I wrote a good chapter, but I also collaborated with a psychologist in the psychology department. And so collaboratively, it has a lot of good information. And so I'm bummed that we don't really touch on that like I feel like it should be, but it's, that's some of the highlights from that are, when you guys get out there, you'll be so happy because nobody's checking you. Nobody's stopping you every 5 minutes, and you just be working and earning good money, and you'll have all this freedom and autonomy, and you'll enjoy what you're doing. 99% of you, 1 or 2 of you may be like, why did I do this? No. I mean, there are always people who end up going, not as much as fun as I thought, but in general, you guys really will. We saw it, like seniors that just graduated, at the conference, and they were all like, oh, I'm so happy and I love my job and it's so much fun, and that is usually how you feel, but you have a lot of energy when you first get out, and you can easily wear yourself out over the course of, usually it takes a couple of years, it doesn't happen overnight, but you go in with so much gumption and wanting to pay off loans and get a new car and upgrade your housing or something, and the money's flowing in and you just work harder and harder. And a lot of times hygienists can face burnout. And I think in general, healthcare has a high rate of that, because, you put a lot of personal emotions out, and it's also physically challenging. So just think of things, you will work hard, and working hard is really good. Like, you shouldn't sit around in an office on your phone. Like, that's not a good job. You should be working hard, but remember, like, there's a balance. So during a day, you should have time for bathroom breaks and water breaks and stretch breaks. And if you are not working for an office that doesn't respect that or understand that you have 10 minutes every once in a while to like have a snack, go to the bathroom, like there has to be a balance in your day. And yeah.
I mean, isn't that also federal law?
It is, but it doesn't, I mean, I can't tell you how many offices I worked for that from 8 till noon, I just went. And then my lunchtime came and I had a break, 45 minutes or an hour, but in like 4 hours, like there was barely time to pee, and it is law, but it doesn't always happen. And so you have to kind of advocate for yourself and say, I realize my next patient's here, but can someone turn over my room? And then you help somebody when you have a minute. Like, it's just, and a lot of offices do work like that, but a lot of times you can feel pressured to like go and go and go and go and go and work more and do more. And you just have to remember that there has to be a balance. And 5 days a week of hygiene is a lot. And everyone does it to some degree, like a little bit, but try not to do it forever because it's hard. 5 days a week of hygiene will burn you out faster than anything. I did 5 days when I was temping, like when I was pregnant and I wanted to earn a little extra money, but I never sustained 5 days consistently, but I know some hygienists do because, they just, for whatever reasons, whatever their personal situations are. But anyways, so just a little nutshell about that. And I'll send you guys, if anyone wants the chapter, once it comes out, I'll email it to you. It has some good like burnout prevention strategies. And it also talks about mental health for patient care as well. But okay, so that's that. We'll go over eating disorders and substance misuse, and then here where did I put it? Oh, that's right, I put it on 14. Okay, we're on this is the week that we're actually doing this, 14. So then I put HIV and oral health, the recorded lecture. And I actually did this recording like 2 years ago, but I was listening to it and I was like, yeah, that sounds okay. And so I posted that one. So it should follow the same PowerPoint. And then I just recorded these over the break. So these for sure have everything that and I do believe this one does too. I scanned through it and I think it's just as up to date. But then, so there's the 3 recorded lectures that you should have, not necessarily for the final. You don't have to feel like I have to read these and write down notes for the final, but you do need them for general practicing information. Like there's a lot of good information on patient care. So you definitely want to listen to these recordings. And then what to focus on for the final in regards to these 3. So that's not just like in general, that's just in regards to these 3, because I didn't lecture on them. So I don't want you to feel like you don't know what to focus on. So for HIV, and so there'll probably be like a question, like a question for each one of these points here. So how HIV is transmitted, for person to person, that should be from person to person. And there's like slides. So when you go into the HIV slide, look for the slide that talks about transmission, and then look for the risk. It's like the last slide for dental providers. So you should know like how in general is HIV transmitted. You may know this anyways. And what are our risks? Most common oral cancers in a person with HIV/AIDS. So there's a slide that has that information. Oral manifestations, this is a little bit more, there's like several slides, but look for like, I would want you to focus on things like when someone is immune compromised and their immune system has really dipped down, what are some things you might see? Maybe more herpes simplex, more candida, the Kaposi sarcoma. Like there's certain things that are going to flare up because their immune system is compromised. And then for the clefts, I think I forgot to type something here, but so the orophacial clefts and the physical complications, there's a slide that has that as like a header or something similar to that. And then the dental hygiene role in caries prevention for orophacial clefts. So children who have clefts have a much higher caries risk because they don't clear food as easily. Like they have this structural anomaly that can really like, it might be missing teeth. There might be like strange curves of the arch. It's not just a smooth horseshoe shaped arch. There's like, divots and all this stuff from the malformation of the arch and the teeth. So there's difficulty clearing food. There's a communication with the sinuses usually, because sometimes it's open to the sinuses. So there's all these things that make them higher risk for caries. So what are some things that we would focus on for that? What would we talk to the parents about and things like that? So you want to just look for that slide. And then orthodontics, when to refer to a specialist. So what are the things when you're looking at like a 7-year-old kid, what are some of the things, or 8 or 9, whatever age, what are some of the things you're going to look at? Well, a lot of crowding, TMJ issues, there's different things in there that will be highlighted. I think there's a slide that says when to refer. So focus on this verbiage for each one of these and look for the corresponding slide and know that material, because likely like 100%, I will write a question based on that. And then describe the effects of orthodontic forces on the teeth and the periodontium. So like the effect of orthodontium on the alveolar crest, minimal. And sometimes it's positive. Sometimes bone comes back, like if the tooth is tipped and then they straighten up the tooth, sometimes the bone actually raises up. What's the effect of orthodontic movement on the pulp? Well, if the force is too hard, then it can cause some trauma, permanent trauma, but in general, it's transient and minimal. So that's what you want to know. What's the effect of orthodontic therapy on like the root. Well, if the tooth moves too fast, you'll get blunting of the apex of the root. So you want to know those are like big take home points that you want to know. So there's like maybe 5 or 6 things that can happen with orthodontic movement and how it affects the periodontium. So you should know those. So that's it for those things. And then we'll go over, next week, we'll just, I don't know that we'll take the whole class. I'm going to take some time for you guys to fill out the course evaluation. And then we're just going to go over what to study. So I'll just like talk through, we could do a Kahoot. I have a Jeopardy game. We could play the Jeopardy game. And then I may have a Kahoot already built. I'll look and see, but I can just go through the study guide with you and like say, this is my thought process. This is what you need to look for. Because the study guide, seriously, if you apply the study guide like really well, you will be very prepared for the final. If you kind of just look at it and don't think that deeply about it, you won't be prepared. But the study guide like follows the questions correspond very well. It's not like 100% of the questions, but it's enough to give you a decent passing grade if you really utilize the study guide. And then the Jeopardy game too has quite a few as well. So you just really have to like pay attention to it and memorize it, like study it, and so that it sticks with you for the day of the exam. Okay, so that's it for that. And then we'll go, I'm gonna bring these back over here and we'll go over the PowerPoint. And this thing here, this sheet, that's in this week. That's in week 14. That's a Google link. You can click on it and keep it for your records, for your record. So we'll do eating disorders first. And there is so much more information. I was looking through this. Oh, I want to share this. Hold on. I was looking through this PowerPoint earlier last week, and I was like, oh my gosh, this PowerPoint is pretty lackluster. I think it's just from the book. It's from Darby and Walsh. And because they'll give you PowerPoints as like a bait, like this is like the base knowledge of what Darby and Walsh wants the students to know. And so I think I just have it without having kind of embellished it with different information. And there is so much information on eating disorders out there. So this one needs to be revamped. This is probably one of the last ones that I haven't really done much with, but these are just the objectives from the course. Some of these are probably, or from the textbook, but some of these might not actually correspond so great. But let's see, describe the diagnosis and epidemiology of both. I don't think epidemiology is hit in this slide, but the diagnosis is touched on. Discuss oral and overall health effects. That's a good objective. Develop a dental hygiene care plan. Not so in depth like it talks about here, but it is touched on in this PowerPoint. Discuss the need for interprofessional collaboration. Definitely a person with an eating disorder will be under the care of many other healthcare professionals. It's very challenging if somebody has severe eating disorder and it's completely disrupted their life and their health. It can be very challenging to treat. And so there's usually several healthcare providers that are trying to help somebody recover. List resources available, and that is in there. That's the last slide. Okay, so the APA, the American Psychiatric Association, they have classified eating disorders as a mental disorder. So it's really not just something like somebody's just, being like fussy or, self-conscious, or, it's not like just some little thing where, I just want to have, the perfect body. It's like all encompassing, really mental, mental health, pain and suffering. I mean, it's a really all encompassing, especially if somebody has really severe and they're really in the grips of it. So it is a mental disorder that needs counseling, and sometimes there's some medication, but a lot of kind of close observation and help for somebody. Sometimes they have to be in an inpatient sort of treatment situation for a while to really break that mindset that they may or may be in. So that we'll touch on these couple different ones: anorexia nervosa, bulimia nervosa, binge eating disorder, and then we don't really go into these at all, but just to be aware that they exist. There's compulsive overeating, compulsive overexercising, night eating syndrome. I think I may have that. I'm like, do you wake up in the middle of the night, or does that just mean you get snacky at night? Because I get very snacky at night. And then sleep eating disorder, which that can actually be triggered by like medications. Have you guys heard of, like, when people who take the sleep drug, not Ativan, what's the one that people take to sleep? What? Ambien, yes. And how people do all kinds of funny things sometimes on Ambien, like get up and drive their car, or get up and eat, make food and eat. So I'm sure that's somewhat different from somebody who does this without medication, but that's kind of a interesting side effect of the medication. So dental hygienists, we're ethically responsible to help patients access health care. So what's really interesting about, especially somebody with bulimia, is obviously there's going to be an effect on their teeth. Even anorexia, we may notice some things, in general, people may notice somebody that looks, very thin, skeletal, or, has, physical signs that look like maybe they're not, eating enough nutrition on a very regular basis. But with bulimia, we'll see some of the first signs in the mouth, and they may not think that anybody notices or that anybody can tell, but you'll be able to tell. So it's actually a really good opportunity to ask some very benign, non-accusatory questions. I've had patients in the past who have had very definite erosion. And I had one lady who was maybe in her 40s. And so, and she had some, I think, past issues with it, but not current. So that's the thing about it too, is you don't necessarily know. It's not like it's happening right now, right? Because erosion doesn't grow back. Like, once they lose that tooth structure, that sign of that damage is going to be there. It's like a scar, but it doesn't mean that it's actively happening. So it can feel like a little tricky of a topic. But care is enhanced by patient-centered collaboration, and so a lot of communication with other healthcare providers. So the 3 diagnostic criteria for anorexia nervosa is restriction of eating relative to required nutritional needs, resulting in significantly low body weight, irrational fear of being fat or gaining weight, a lack of recognition of the health challenges due to the restrictions and the thought process. So not realizing that they're literally starving themselves, the damage to their heart, like just not even considering how severe the physical ramifications are of their condition. And then just having the fear just be the thing that bulldozes them and keeps them going in that same direction of not eating and kind of starving themselves. So 2 specific types: there's the restricting type, and then there's the binge eating and the purging type. So the bulimia nervosa is characterized by repeated binge eating, and it's said in the book purging type and then the non-purging type, but I had a hard time finding, and if somebody finds it, if they're perusing the textbook at some point, let me know what it says. But I had a hard time figuring out what they meant by non-purging, but then I thought, well, maybe they mean like laxative use, but that could also be purging, just the other end. So I'm not sure, but sometimes heavy laxative use is also part of it. But if they're binge eating and then they're not purging it, I'm not sure where that leaves it.
Like, okay, never mind.
You think of something or find something, tell me. For diagnostic criteria, eating significantly more food than what would be considered normal amounts, doing so without control, and basically just overeating. Purging behaviors to offset the binge. So I think it's a strong, I mean, everybody, snacks while they're studying, or, eats too much at Thanksgiving, or, does things like that. But when it's consistent, or when it's severely excessive, and then there's this guilt and this feeling of having to purge. So binging and purging behavior, they occur approximately once a week for at least 3 months. So somebody has to be doing it like really pretty consistently. If they do it once, like a year or something, that's probably not, it's probably not great, but it's not necessarily considered diagnosed bulimia nervosa. Individual sense of worth is dependent on their body weight and shape. That usually has a very strong component. The health effects of anorexia and bulimia treatment is challenging, and the recovery period is very lengthy. Dental hygienists must be vigilant to support recovery. So just doing what obviously we're not experts in mental health, and that's outside of our scope of practice completely, but we can, empathetically share the effects on their mouth, and how sometimes appealing to someone's cosmetic, or aesthetics, sometimes that can be a motivating factor, and so talking about the effects on the teeth and the long-term health of the mouth, that can help somebody sometimes get a different perspective, and just realizing that there can be setbacks, and it can be a very lengthy process. And then of course, always remaining empathetic, which is just sort of a go-to for all of our patient interactions. So the psychosocial dimension, anorexia nervosa, there's a control of food, perfectionist, there's sort of a personality type, this kind of control, needs to have a lot of control, a perfectionist. A lot of times that kind of goes hand in hand. There's a good website at the end that you can just kind of peruse and click through, and it talks about, susceptibilities and who is susceptible and different. It practically has all the good information that you'd need, more than I feel like this PowerPoint, but you can just kind of click through it and see a few interesting things at your leisure. So control of food, perfectionist behavior, bring feeling of competence and control to their lives. Sometimes it's being able to micro control the amount of food and water that gets into their body, brings a feeling of normality and reduces anxiety and gives them positive feelings that they're lacking tremendously. And so that can be the thing that keeps perpetuating the cycle forward, is that they're feeling a sense of accomplishment or a reward from restricting and from controlling. Bulimia nervosa behavior becomes self-reinforcing, because they're able to, kind of eat like maybe a large amount and then purge and not gain the weight. And so it sort of is like, oh, I can keep this habit up. Dental hygienists should understand that a key role is to help patients with their human needs for conceptualization and problem solving. So the human needs of having a healthy dentition and, overall good health and these kind of things. So those are some of the things that we can talk to the patients about. So other physiological responses for anorexia, there's impaired individuals' overall functioning and health. So overall, it's gonna be a detriment to their overall health, and their oral health for sure, but also their physical health. Like there are a lot of permanent cardiac issues that can develop, and just a overall feeling of fatigue and malaise and not feeling their best, not being mentally as sharp. When you lack nutrition, your whole system suffers, right? Hormonal abnormalities, and then vitals, like their blood pressure and all of these things will be affected as well. For bulimia, dehydration or electrolyte imbalance is a big one, gastric dilation, and then inflammation of the esophagus, or even tears or trauma of the esophagus as well. So not small stuff, like a bunch of, pretty serious things can come from it. Other general physical findings, common physical findings for patients with anorexia. So lanugo. And I this is where I should have some pictures pulled up, because I have looked up the pictures, but a fine downy hair found on the lower half of the face and then the upper body can develop, and I'm not exactly sure why that develops. And then feeling cold, which totally makes sense. I mean, there's with hormonal imbalances that affects temperature regulation in your body, and then just being super skinny and not having, you know, anything on your body to help kind of help regulate your temperature. But definitely probably the nutritional and hormonal balance would be a big one. There could be some thyroid issues there too, and so that could be affecting that constant feeling of cold. For bulimia nervosa, they could have trauma on their hands. Sometimes they don't always use their fingers because the trauma gets obvious, so they may use a spoon or something else. Oral lesions and bruising from the repeated gagging themselves to induce vomiting. So this is a big one, parotid gland enlargement. That's like a good board question. You should just highlight that to remind yourself of that. Diminished taste acuity, dehydration and xerostomia. The paramylosis or enamel erosion is just easier to say, but this word could pop up on a board exam. Intraoral trauma, increased risk of dental caries, periodontal disease. They're, especially with anorexia, if they're severely deficient of nutrients, vitamins, and minerals, they're going to be more susceptible to disease, so caries and perio. Intraoral trauma, that's repeated, other comorbidities, and then side effects of medications, and then just an overall systemic health issues. And there is a bunch of stuff in the notes that I think I pulled from the textbook. So this is in the text if you want to look at the specifics of this, but there is an assessment called the SCOFF questionnaire. And if you are suspecting that you have a patient in your chair, especially if they're a younger lady, and you're seeing, you know, some of these oral signs, and you're suspicious of it, you can talk to your doctor about ways of broaching patients and offering this questionnaire to see where they lie. You're not going to be tested on it, but you can look that up in the textbook. So for the dental hygiene diagnosis, for the planning, excuse me, 3 phases of planning. The first one is if you say something to your patient, I just liked this script a lot here on the handout. It says, my dental hygienist, this is just from the textbook, but it says, my dental hygienist was the first person to help me disclose that I had bulimia nervosa. When she looked in my mouth, she saw signs of erosion and asked me about them. It was how she asked me, her tone of voice, calm, kind, and empathetic. They enabled me to be truthful with her. That enabled me to be truthful with her. I had never spoken a word aloud before. When I said them to her, I throw up many times a day, and I've been doing this for a couple of years. I think I have bulimia. My dental hygienist helped me contact an eating disorder clinic, and now I'm on my way to recovery. And I just like the way they posed that, because it wasn't like it's a nice way to broach that topic. Like, oh, I noticed that you have widespread erosion or loss of enamel on all your lingual surfaces. And one thing that can cause that is a lot of acid reflux, but also a lot of vomiting or throwing up. Do you throw up a lot? And it's not like you're saying, like, do you have bulimia? Like, you're not accusing them of it. You're just sharing information. And that would be a very sort of, kind of like I don't want to use the word confrontational, because it's not confrontational, but you know what I mean? It's just a nice way to bring it up and give them the freedom to answer in the way that they feel the most comfortable. And sometimes you can pick up from the way they respond too. They may not be ready to disclose it, but you might kind of get a sense of where the patient's at with their mind frame about that. So but if they do admit it to you and actually disclose that they believe that they have a problem, the first thing would be to really help them, encourage them to connect with a healthcare provider, and then establish a dental eating disorder team, of course, you're not going to establish it. That makes it sound like you have this whole big, but just making sure that you're in contact with a healthcare provider, that you're finding out where they're at if in their whole routine, and that they come back and see you quite often so that you can do things like ensure that they're using fluoride trays or fluoride toothpaste or daily xylitol products or whatever it is, whatever you go over with them, to just keep them in a good standing as much as possible with their oral health. Support the patient's human needs, specifically management and support of their oral health during and after the eating disorder treatment. And then record the human needs deficits and set, I know sometimes our notes don't look like this, so I always think like, not every hygienist writes notes that talk about the human needs, but you guys learned it in, I know in Monica's class for sure, she goes over it. So it's, like measuring their freedom from pain, their sound dentition, responsibility for oral health, how capable are they of being responsible for their oral health, or is something getting in the way? Is a mental health issue getting in the way? And then wholesome facial image. So those are just some human needs from way back in the earlier chapters of Darby and Walsh. So implementation, phase 1, referring the patient for medical and psychological treatment. Phase 2, role and responsibility of the dental team as part of the patient's interprofessional collaboration. So keeping in touch with whoever they're getting their treatment from. Phase 3, management and support of oral health during and after the eating. So this includes monitoring their erosion, the dental erosion. So taking pictures once you notice it, taking intraoral images, and then sort of keeping track to see if things are getting better. Well, they're not going to get better, but getting worse. Effect of the diet on oral health. So talking to them about what foods maybe to avoid, especially since they're more susceptible. Oral self-care, pain management. So the objective of the evaluation, baseline findings and accurate measurements. So this is sort of just common knowledge, but you want to record what you see and you want to monitor to see if things are progressing or stabilizing. And then involves the use of awareness of verbal acknowledgement. So just, does your patient agree? Are they on the same page with you? Or are they sort of just shaking their head, but kind of somewhere else? Are they on board? So for patient-centered care, we always want our patient to have full informed consent, risks and benefits. And so they need to know what's at risk if they don't do what we're recommending, and are there risks if they do what we're recommending. Collaboration. And then this is sort of just going over stuff, but interprofessional, these are some interprofessional healthcare providers that you may be in contact with. And then this national eating disorders.org, this, I really like this. These are some other resources, but this one I really liked. It had a lot of easy to digest information. So I would recommend going here and just kind of looking at the bulimia and the anorexia. It talks about, like who's susceptible and just all sorts of different things. It's a good all around website. So I would encourage you to look at that. And that's all we're going to cover for this. As far as important points, it's really important to know, this stuff. And I would even refer back to Darby and Walsh just to pull up oral health implications, because you'll get questions. There's a few questions on the final about oral health effects for anorexia and bulimia, but you'll get it on your board as well. So there's not a lot of there's not a lot of special needs adaptation that you'll do as a hygienist for somebody with anorexia or bulimia, but you will notice the oral health effects from the practice of either, like nutritional deficiency or throwing up a lot. So it's real. And then things like that, like the parotid gland enlargement and things like that. It's really important for you to know those signs, and especially of sort of uncontrolled current, a state of current, either anorexia or bulimia. So know those for sure. Maybe this as well. And maybe this as well. So just those real physical things that you may pick up as a hygienist. So that's this one. Let me stop sharing this and then I'll pull up the substance misuse. If I can find it. Nikki. I know, and we keep it at the end, right? Should this stuff go at the beginning? Is this better to share at the beginning? It's like, by the way, blah, blah, blah. And this is another one, substance abuse or substance misuse. There is so much information. These are the kind of topics that it's kind of like the child abuse and the human trafficking. Like these are like huge courses all in their own. And so I highly recommend you guys, when, those are the kind of courses that it's always nice to go for a pharmacology review or, you have to do that stuff. But these are the kind of courses that tend to be more interesting and you get a lot of good tidbits that you either kind of glazed over in school or, there just wasn't enough time to go in depth. And the opioid crisis, oh my gosh, if you want to be really mad at the world, or if you want to be really mad at pharmaceutical companies in general, do some research on the opioid crisis from like the 90s. And I mean, just the outright profit over people mentality that the pharmaceutical companies have. I mean, the things that they have done in the name of, like good medicine, but really knowing the addictive nature of things and just really putting profit over people. I mean, that's just all it comes down to. There is some crazy information and documentaries, and the residual opioid crisis that we've been dealing with for decades now, has stemmed from it. Well, and now there's a lot of issues with the fentanyl coming in too from overseas, and it's strong. Who watches Dr. Phil? I never watch Dr. Phil. Does anyone watch Dr. Phil? He's so weird. I didn't even like him back when he was like, he had such a strange delivery that I'm always like, oh my word, stop it. But he was on Joe Rogan. Does anyone watch Joe Rogan? He was on Joe Rogan and he was saying how there are these apps, and I don't even know that this is true or exists. I mean, I don't even know that because I don't use it, but this is what he said, that there are apps that you can actually like order a pill, and you can put in and order a pill and they'll send you like one pill. It's like delivery. It's like a delivery system. And he said that it's fentanyl that's unregulated, and it's comes in so strong that that's where there's a lot of these fentanyl deaths. There's a lot of overdosing. And the fentanyl comes in so strong and it's completely unregulated, and they just make these batches at these incredibly high doses that like literally one pill or a half a pill can kill you. And so he was sharing some stories on Joe Rogan, and I don't know if it was, I'm assuming it's at least somewhat factual, but it's insane. And there is just a lot. You can do a pretty deep dive on the opioid crisis, and it matters for dentistry because dentists historically have provided a lot of prescriptions for opioids because we take out wisdom teeth, we do oral surgery. And and so I think sometimes I've seen in the news, like dentists almost get like a bad rap. But theoretically, dentists don't prescribe opioids for like long term. So I've seen stories where the dentists are the blah, blah, blah to prescribe opioids. Like, yes, that there is truth to that. And so we should be very aware of it. But dentists don't usually continually rewrite prescriptions for the same patient. The flag goes up and they're like, yeah, you don't need that anymore. And so, but in these pain facilities where people go for like neurologic pain or back pain or some, they may legitimately be in pain. Those are the places where they're going to be on pain meds for like a really extended period of time. Oh, hold on. Okay. So anyways, there's just a lot of good information out there. If you want to look for it, you'll find it. But these are the objectives for this lesson here. So kind of talking about the concepts of substance abuse and alcohol misuse, discuss the illicit drugs, over-the-counter drugs, a little bit into the schedules and some of the different types of illicit drugs that are out there, list and discuss the various causes of substance abuse, also summarize the action of the psychoactive drugs on the neurotransmitters, just kind of barely breezes over it. Explain which medical treatments are used for various substance misuses. So this is important, like you need to know the medications, especially for alcoholism. There's a big tip for you, star. If someone's an alcoholic and they're prescribed a medication, you need to know that medication for the final. Explain which medical, oh, I already said that. Analyze the dental hygiene process of care related to patients with substance misuse problems and those in recovery. Discuss why dental professionals may be at risk for chemical dependence. Did I tell you guys about the dentist I worked for in Arizona that was addicted to pills? Did I tell you? He was definitely addicted to pills, and so was his wife, and they had 5 kids. And I worked for him for about 3 years. Sweetest man, very quiet, but he was so obviously sedated. And he would go home at lunch and he'd come back and he'd be a little more sedated. And I didn't really know for sure he was on drugs until like he lost his license and had to go into treatment. And then he got his license back and he could continue to practice. But there were times when he seemed like one step away from falling asleep on his patients. And I was like, this is really kind of scary. But he didn't lose his practice. The board just took his license and he had to go to treatment. So it can happen. He wrote himself and his wife prescriptions all the time for pain pills. So what to consider? So these are the questions on the health history that, will kind of trigger maybe some of these topics. So substance misuse is sort of the more appropriate term. It's hard to relearn terms. So younger generations usually go with the newer term. I still say abuse because that's all I ever knew it was called. But the newer term is misuse. The substance abuse kind of comes with a little bit more of a negative connotation. And there is a lot of substance misuse of all different things, different types, and different people in all different stages of life, older, younger, rich and poor. I mean, it is very ubiquitous. It can affect lots of people. But substance misuse is a pattern of self-administered drug use that may lead to drug addiction. And then a substance is any psychoactive compound with the potential to cause health problems, substance use disorders, or addiction. And mostly we talk about these 3 categories: alcohol, illicit drugs, and over-the-counter drugs. And then that's just the difference in the term, like I just mentioned. So research has shown that drug addiction is chronic and it's a cyclic disease, and it's unlike other diseases. There are other diseases, I think, that have a social stigma, but in general, substance abuse can have, you almost feel like, oh, get a hold of yourself and, straighten up and start, get your life together. Like people might have that sort of an attitude without realizing that there's a psychological component. Sometimes there's a self-medicating component. It can be very layered. And so there can be not impatience, but maybe an impatience with people with substance misuse disorders. And so there is that sort of social stigma, but I do feel like that is changing, hopefully for the better. Poor oral health is very common. Obviously, not only can there be an effect because of the drug, but also just the lack of self-care. So that can be a part of it. Substance misuse directly affects oral health, xerostomia, increased caries, enamel erosion, periodontal disease, poor self-care. So for addiction, dependence, withdrawal, and relapse, drug addiction is the prolonged repeated misuse of any substance, chronic and compulsive need to take the drug despite the negative consequences. Psychological dependence is rooted in the belief that the drug is sort of needed to maintain a state of well-being, or you know, that kind of revisit that feeling of good mental health, even though every time maybe they fall harder and harder into a darker place, but then come back to hopefully what feels like a better place. And so it kind of is this self, you know, fulfilling cycle to try and get themselves back into a place of well-being. Psychological dependence results from a biologic alteration of the user's brain from consistent drug use. So, you know, we have neuroplastic minds, right? And we form habits. And when we follow those same pathways, those same neurologic pathways, we reinforce them. And so if we're using a substance that reinforces something, then that can be another layer to that addiction or that need to keep taking it. Withdrawal symptoms may include pretty uncomfortable feelings. That's another reason why someone wants to re-administer the drug, is to not feel these withdrawals, but vomiting, diarrhea, rapid pulse, sweating, anxiety, convulsion, severe cramps, high blood pressure, a severe headache. And then drug tolerance is, you know, just, you remember that from oral med, just increasingly needing larger and larger doses to get the same effect. So this just goes over those withdrawal symptoms again. So illicit drugs are a variety of drugs that are used for non-medical purposes, and they're generally speaking illegal to manufacture, sell, or use. And then over-the-counter drugs, the drugs you can go and buy, like Tylenol. Drugs, certain substances and chemicals are classified into 5 categories or schedules, and these substances are scheduled in relation to their acceptable medical use. So like marijuana was never, they were like, marijuana has no medical use, even though for years people have been like, yes, it does. But the government, you know, has said, you know, for decades, no, that's, you know, so it's been like up there with heroin and, you know, some of the harder drugs. But some of that I think is shifting a little bit. I think they've changed marijuana on the schedule, but I could be wrong. I don't follow that super closely. But so alcohol is the first one we'll go over. It's the most pervasive substance used in the US, associated with negative oral and overall health-related diseases and deaths. The liver breaks down alcohol at a rate of 1 standard drink per hour. So that's, you know, a good measure of, you know, if you're going to get intoxicated or, you know, drunk or just a little buzz, depending on how much you drink in an hour. And then 1 in 8 Americans, and I looked last night to see if this was updated because I've heard the rates of alcohol use have gone up, especially through COVID, but nothing on the CDC or anything looked much different than this statistic, which came out of Darby and Walsh. But 1 in 8 American adults, or almost 13% of US population, now meets the diagnostic standards for alcoholism. And that I didn't see any numbers that looked more than that. And some of them on CDC actually looked less than that. So, but in general, there's been a lot of published information about the use, the drug and alcohol use going way up since COVID. So I don't know, maybe there'll be some studies that come out. So here's just your typical, these are all roughly the same amount of alcohol, you know, but like 12 ounce of beer is the same as 8 or 9 malt. Who drinks malt liquor? Does anybody drink that? Yeah. Poor like high school seniors who want to just grab anything they possibly can find. 5 ounces of wine or 1.5 ounce of pure spirits is it's all roughly the same amount of pure alcohol. So alcohol poisoning, some of the signs of alcohol poisoning is a slow or irregular breathing, so less than 8 breaths per minute. Person would be look very cold and feel cold and pale and maybe even possibly a blue tinge to their mouth or fingernails, rapid pulse, and then if they could deteriorate into vomiting while awake or sleeping, and then if they're hard to respond or you can't get them to wake up, semi-conscious or unconscious. Signs of chronic alcohol abuse, like someone that is, just drinking a lot constantly or maybe all the time. Redness of the facial skin, spider petechiae on the nose from dilated blood vessels, yellowish facial skin from jaundice, so related to the liver just not functioning as well. So once you start to see some of that yellowing of the eyes and skin, the liver's not doing so hot. Facial trauma, perhaps, if they stumbling and falling, and then angular cheilitis or cheilitis related to predominantly vitamin B deficiency. So yeah, their immune system also probably isn't tip top, but it may actually be more from the vitamin B deficiency. And then red or swollen eyes. Intoxication, everybody probably knows what this is like, but poor judgment, impulsive urges, slurred speech, unsteady gait, lack of coordination, impaired memory, attention, involuntary rapid eye movement. My sweet neighbor, who I love so much, and they moved to Spokane, but she probably still is, but hopefully she's getting better. Definite like alcoholic, and she would come over drunk, and all times of the day, and her daughter's my best friend, and so she would tell me some things too, like, oh, mom's drinking is really bad. But she was bruised all the time. Because they had stairs, and she was constantly falling up and down the stairs. And so you worry, like, not only is their liver, and their health not doing well, but physically, like, you just feel like you can't turn your back on them because they'll go tumbling down the stairs and, break their neck or something. So it's very, very, it's very stressful for the family. I mean, that's without saying. Marijuana, so that's the gist for alcohol. So for marijuana, it's mostly the most commonly used illicit drug in the United States is marijuana. And as of 2017, so I looked this up again too, just recently, and it doesn't look like this has changed either. There was a map I pulled up, like, where's marijuana legal? And I counted up the states, and it looks like it's still right around 29 states where it's legalized. There's some pending stuff in a few states, and then there's a few states where it's not legal. Research suggests that there's potential therapeutic value for marijuana use in positively affecting several health conditions such as pain, nausea, epilepsy, obesity, addiction, autoimmune. I watched a really interesting documentary years ago, and I don't even remember what the name of it, but it was an older guy in Nova Scotia, Canada, and he had some kind of cancer. There was two different stories. There was a little boy who had a childhood cancer, and then there was this older guy in Nova Scotia, and I can't remember, there was something more with his story, some kind of, he was trying to bring about awareness. But they both had pretty severe cancers, and they were treated with some kind of very high dose cannabinoid. So it wasn't the THC, it was just cannabinoid tincture, some kind of, and there might have been something else in it, but mostly it was like they were treating their cancer with marijuana essentially. And they were, went into remission and stuff. And that's very anecdotal. Who knows if that would happen with anybody? But the point is that there is a lot of science out there that they've been doing research in labs now more and more, and they just have had a hard time funding it until recently. So there is more research happening in this realm with some of the properties of the cannabis plant. And there may be, that's where we get medicine. Every medicine comes from a plant. And so it's not surprising that there could be like life-saving medicine in a marijuana plant, because that's where we get all medicine from plants. Yeah.
I think it's right, it's not. But they want to live there. They're both like,
Mm-hmm.
another person had really like a piece of paper that was so bad that it was debilitating. They get into work out,
Mm-hmm.
and they would
Would go away. Yeah, so it's working on, it's similar with, that might be similar to like epilepsy too, like it helps epileptics not have seizures, and so there's something, does something in the brain, so maybe a similar, you know, who knows what neurologic condition or something, but yeah, there's a lot of interesting stuff out there. Yeah. Mm-hmm. Mm-hmm. Yeah. And now she gets them like maybe once a week. Yeah, so way less. Yeah, my friend's husband has used marijuana for years for his epilepsy, and he doesn't have seizures. So yeah, it's interesting, you know, it's hard when there's potential for benefits in something that's like off, you know, nobody can touch it, nobody can research it, but then, you know, things change, and if they figure out they can make money from it, oh, they'll do it. So but yeah, so there's a lot of potential. So cannabis, there's different names. You've all probably heard all these different names before. Reefer, does anyone say reefer anymore? Reefer Madness, has anyone seen that movie, Reefer Madness? It's from like no, I think it's from like the 60s, maybe 50s. I think it's a little more before the 60s. I think it's 40s, 50s, maybe. But oh my gosh, it's hilarious. But that's what sort of was the propaganda to get everybody to think that marijuana was like insanely scary and dangerous. And so they would play this movie, Reefer Madness, and it was just propaganda, just government propaganda to mislead people and put fear, like, you know, make everyone afraid. And so that was the only time I've ever heard anyone refer to it as reefer. But anyways, so the tetrahydrocannabinoid THC, that's what gets you high, and then the cannabinoid CBD is what you see with the lotions and the everything that people use for whatever aches and pains, sore muscles, things like that. So there's a psychoactive ingredients, and then there's the analgesic and anti-inflammatory. It's also anti-nausea property, you know, all these things. That's why cancer patients sometimes will take marijuana in different forms to help with nausea so that they can actually eat and have an appetite. So in the short term, there's can be relaxation, a feeling of euphoria. There could be some confusion. Red, you know, bloodshot eyes is sort of the, you know, the sort of cardinal sign of someone who has smoked pot. Intense hunger or thirst, difficult with concentration, memory, learning. But it can also kind of, sometimes people hyper focus too on something. And then distorted perception of sight, sound, time, and touch. And then systemic effects, there can be dilated pupils, tachycardia, peripheral vasodilation, bronchial hyperactivity, insomnia, impaired short-term memory, disruption of testosterone secretion, decreased nausea, which is a nice effect for like someone with cancer, like I said, and decreased pressure behind the eyes, so glaucoma. So sometimes people with glaucoma will also take some form of cannabis. And then there's all these different forms, lots of edibles out there too. I got a thing from the FDA that talked about some of the ways that they extract the THC and the CBD, and how it's dirty, like it's a really dirty process. And they use weird chemicals to extract it, and can be like carcinogenic and stuff. And I wanted to research it and put together a presentation, because I was like, you know, there's so many things in these shops that people can have access to. And it's like anything. It's like, you're like, well, I don't know, it all must be the same, right? But it's not all the same. And you kind of want to know what you're getting and what, how they produce it or how they're making it. But there's all these different things. And then also things that look appealing to kids, which I don't think is such a great idea either. But they make all kinds of different stuff out there. So for the opioid crisis, we'll just touch on that just a little bit. The opioid is an analgesic pain reliever. It's now the most prescribed class of medication in the US, with, at the time of this book, because I think this statistic comes from the book, 29 million prescriptions written each year. both synthetic drugs and opiate drugs derived from the opium plant or the poppy plant. So some of the examples are obviously, of course, heroin, OxyContin. That's the one that kind of took off. It was, do you guys kind of know the back history just a little about that drug? It was like next level potent, like it worked for pain medication, like incredibly well. Like patients that had chronic pain that they couldn't get any kind of relief from, it worked amazingly well. And it's time release. So if you took it as prescribed, it still was very addictive, and they still downplayed the addictiveness of it. But if you took it as prescribed, theoretically, it would release its medication slowly. Well, people started, chopping it up and snorting it, or, like doing things that bypassed the time release. So if you bypass the time release and you get it all at once, it's a very different effect. And so that was part of the problem with OxyContin, and so that just spiraled from there. And doctors were told by sales reps, that it wasn't addictive. It wasn't any more addictive than whatever else that they used. And so there was a lot of serious misinformation, like legitimate misinformation for doctors. But anyway, so these are some of the different forms, and fentanyl, this is the one that used to be like fentanyl. Oh yeah, go ahead.
I was in like oxycontin practices,
Mhm.
so like I don't know about it, but
Yeah.
and then it's just like the way they plotted.
Mhm.
You find yourself at that point, like people like the tolerance for it, and then obviously I'm to like move down, they go to withdraw.
Yeah.
And not even realizing it because the healthcare professionals.
They gave it to them
And then just started to realize.
without even, yeah, and babies too are born with, addicted, and too, I mean, there's just so many. It was not handled, and there's probably still is tons of situations where it's just not handled appropriately. And then so yeah, and then who wants to withdraw while they have cancer? Like, you're already miserable enough, and then you're like trying to withdraw off of a pain medication. I mean, it's just awful. Intoxication, it's extremely dangerous just because we're talking about, like not breathing, like it's shutting down your central nervous system. And so if you just kind of can go into like a sleep mode, and then you're out cold. And so it's not just like like something like marijuana or alcohol. For sure you can overdose on alcohol and have alcohol poisoning and potentially die. But the opioids can be more subtle, and I think you can overdose without, my brother-in-law, he overdosed on heroin, and he definitely didn't mean to, but it was a bad batch, and he just got too much, and so then you just kind of slip away. So opiates can depress breathing by changing the neurochemical activity in the brain stem, where the autonomic body functions are. So autonomic, all the things that just happen, like your breathing, heart rate. And then opiates can change the limbic system, which controls emotions, to increase feelings of pleasure. So we won't go into it because it's just too much and kind of out of the scope of what we need to know. But the limbic system plays a big role in like addiction and this sort of cycling of, feeling like you need to continue to take the medication to get that same feelings, because it plays on emotions so strongly. And then opiates can block pain messages transmitted through the spinal cord from the body. Well, great. If you have a big wound, you want your pain, to be blocked. So there's a wonderful purpose, but we just have to use them correctly and understand the medication. So this, you don't have to know this for any exam or anything. It just highlights the limbic system a little bit. Just a little review. I don't know that this is actually true. Is this the one that says it? No, it might be the next slide. This just psychoactive drugs disrupt the normal functioning of neurotransmitters, which that is true. I mean, it works on the neurotransmitters. So how much is being released? How much is keeping those different neuron communications going, and then how much is being reuptaked and back into the neuron. But sometimes this is desirable if it blocks pain signals. Great, that's what we want it to do. And sometimes it's not desirable if it's just giving somebody a high or something, or causing them to pass out on or cause their heart to stop beating or stop breathing. Examples: effect is desirable if the physician prescribes morphine to alleviate pain in a person with a terminal illness. So that's obvious. That would be an appropriate reason to take the medication. Oh, this is the slide. I wasn't totally sure. So it says here, some individuals are born with less feel-good neurotransmitters and can't produce as many, and may have a predisposition toward opiate and alcohol addiction. That could be totally true. I mean, that's what it's from the book. However, there's a lot of really interesting information out there about, SSRIs. They're like, oh, you're deficient in serotonin, so you need a serotonin reuptake inhibitor. We want to keep the neuron from taking up the serotonin because you need more in that synapses. So that was like the theory forever, is that you're just deficient in serotonin. But there's actually like gobs of research that is saying that's not actually the case, which is mind-blowing, because that's sort of been the thing that we've heard for a long time. Is and it makes sense, because some people have good effects when they take SSRIs and different SNRIs, and then other people don't have such good effects. And so it's not just this blanket like you're vitamin C deficient, you're serotonin deficient. It was just not, it doesn't work the same way. So when I read this again, when I was reviewing it, I was like, oh, I want to look more into that, because the good neurotransmitters, like, what are they talking about? Serotonin, dopamine, like the pleasure centers. And I'm just interested more in how that works. So these individuals are often diagnosed with depression and look for alternative means. So self-medicating, people are trying to self-medicate to feel better. So the stages of change, you will want to be familiar with this a little bit. I did, in reviewing the exam, there are a few questions on the stages of change. So just knowing, like, where is your patient at, whether you're talking about tobacco cessation, or if they are an admitted, drug user, or, alcoholic or something like that. Usually it'll play the biggest role for tobacco, because sometimes we feel the most comfortable talking with our patients about quitting smoking, other than like, quitting cocaine or something else that they may be taking. But these are the stages. So pre-contemplation, they have no thought of stopping. Contemplation, they're thinking about it. Preparation, they're willing and sort of preparing to quit. They really want to. Action, they have stopped. They're actually implementing something and they've stopped. And then maintenance, they've stopped for 6 months, but it's an ongoing process where they really need to have support and people around them, and they still feel motivated to do it. And then there is the possibility of relapse, reverting back to the substance use. So assess the readiness to quit. Would you like to stop within the next month? So if someone's smoking cigarettes, that's, you can ask them, have you thought about quitting? Or if you have thought about quitting, have you thought about quitting in the next, couple weeks or in the next month? Or, you can just pose that question. So patient-centered collaboration, or communication, it's about collaborating with them and sharing information, not persuading them. So it's a similar thing with just about everything. Someone who's, diabetic and you're, concerned about what they're eating. So it's about education and communication, not about persuasion. Eliciting information, not imparting information. So saying, oh, I would love to share this study, or I would love to share this information I got from this website with you. You might find it helpful, so not like, you need to do this. It's, like, you may find this helpful. Emphasizing the client's autonomy and not the authority or the expert. It's their life, they're experiencing it, they know why they do the things they do. And so letting them feel that autonomy, but just sharing information that you hope will benefit them. so a few things, they may try to pre-medicate somebody who has a lot of anxiety about dental practices or coming in for dental cleaning or tooth filling or something. They may pre-medicate to try and make themselves feel more comfortable in the experience. They potential need to modify or cancel appointments to avoid any drug interaction or behavioral problems. So if somebody, I cleaned his teeth, but I just, the whole time I was like, are we letting this guy go? Because I had this patient at Dr. Matsuda's office and he always came in drunk and he had a crown on every single tooth, like literally a porcelain crown on every single tooth, but he had periodontal disease and he wouldn't let me probe his teeth. So I'm like, you have like $25,000 worth of restorations and you won't let me probe, and he would come in drunk. And I'm like, are we letting him drive away? Isn't this wrong? Should we not let him drive away? Yeah. Yes. And so nowadays, what you guys will learn is you and your doctor, probably younger doctors, because older generation did different things, different ways. But nowadays, if somebody comes in and they can't sign an informed consent, although knowing him, and when I look back at that situation, he definitely would have been like, I'm fine. But then you just have to say, no, you're not. And the doctor has to back you up. If the doctor isn't on board to back you up, it could become very uncomfortable. But yeah, in general, if somebody is not in their right state of mind, then yeah, they really can't sign an informed consent. And so you wouldn't probably, nowadays, you probably wouldn't see him. And then also it's really important for a patient who, if somebody has indicated that they've used cocaine in the past, it's really important to say, I need to know for sure that you haven't had any cocaine in your system or any kind of a something that could affect the heart rate, any kind of a drug that could affect the heart rate, because we plan to use local anesthetic today, and that is very dangerous. That would be very dangerous to combine those. So those things are really important to communicate with your patients. These are just some questions, again, that you can talk to your patient about. Have you ever felt the need to cut down? Have you felt guilty or bad about the amount you drink? And have you ever used or had a drink first thing in the morning to kind of get you going? So just a few questions, and you can talk about it, remaining confidential. So for the process of care, explain the relationship systemically. So IV drug users is a higher incidence of bloodborne pathogens such as HIV and hepatitis. Long-term alcoholics, there's a lot of damage in livers, heart, kidney, and the pancreas. And that can usually show up more over just chronic use over decades or years, depending on how heavy the drinking is. And then drug addiction, a lot of damage to cardiovascular health, higher risk of stroke, cancer, these infectious diseases, and then lung disease as well. Extraoral for the EOIO, they may appear older or than their stated age. If, sometimes there's just their skin and everything may not age as kindly if they've lived a really hard life with drugs for a long time. If they're currently still using, they may appear unkempt or disheveled, poor personal hygiene. They may want to wear glasses to block the red eyes or the bloodshot eyes, long sleeves to cover up track marks or any from injections or anything like that. Alcohol, odor of alcohol on the breath, lethargic, seeming intoxicated, tremors, especially if they are an alcoholic and haven't been able to have alcohol, tremors will happen. Behavior and speech, confusion, just signs of being intoxicated or drunk or high. There's the meth mouth, the high incidence of rampant decay and erosion. Intraorally, there can be tissue necrosis. The septum inside the nose, the septum can, if there's a lot of snorting of different drugs, it can just burn a hole right through the septum. And you wouldn't necessarily see that, but it could be there. I don't think it would show up on an X-ray or anything, but and then bruxism, teeth grinding, xerostomia, decreased saliva, the meth mouth, and apathy towards oral hygiene and diet and just taking care of themselves. There's just like a low, like meh, just a low motivation for self-care. Appointments, that they might not keep appointments as regular. There may be anxiety to come into the appointment. You may need to keep it shorter. And then for pain and anxiety control, so if somebody is recovering from chemical dependency, pain control is going to be a little tricky. Tylenol and ibuprofen together, like one of each, they work on different receptors. You guys might remember that from oral med. And so a lot of good pain control can happen from taking Tylenol and ibuprofen at the same time. So that can help some people. It can be trickier for maybe other people who have higher, more pain relieving needs. Consult with the physician in regards to local anesthetic safety for chemical dependency. Unrelieved pain can relapse or trigger a relapse. So if somebody goes through some kind of a major dental operation or something, and they're in a lot of pain, potentially, you kind of have to work out all these steps ahead of time for the patient. Controlling anxiety, being aware that some patients may exaggerate pain in order to get a prescription. Those patients, a lot of times, they sort of stand out. All through my whole career, we've had patients in the office that are like, Mrs. Jones is calling for another refill. And, you just know that they're not really in pain. They haven't had anything. And, and you just can sort of, sometimes the triggers, those signs will just pop up and it kind of a red flag is like, meh. And then other times you do have to, if you have someone that's never had any situations like this and they're complaining, it could be trigeminal neuralgia. I mean, it could, so you don't always disregard it, but if you've worked with a patient and they're unwilling to do things, they just insist that they just need the prescription, that's all I need, then that's, not a great sign. And so these are just your process of care, oral health instructions, same that we use for lots of different people with the good oral hygiene. Starting slow with little instructions, not like a bunch of stuff. But these are a few things to focus on. And once they get that down, you can add more things, interproximal cleaning and things like that. When making recommendations, just consider, their physical state, mental state, just like you always would, their motor skills, fine motor skills. Are they in a recovery, in recovery required to make numerous behavioral changes? If they're trying to make lots of changes already, you just don't want to bombard them. That's the main thing. Keep it simple and keep it encouraging. Nutritional counseling, positive reinforcement, and no alcohol products if somebody has been addicted to alcohol. And then methadone for heroin addicts is usually in a syrupy, sugary syrup. So you have to be aware of that as well. And that's true for any medication that's delivered in kind of a syrupy. I know, there's a lot of, I don't know, there's just a lot of things. If the world did things my way, we'd still be in a heap of trouble. I don't think I have all the answers, but I know what you're saying, Nikki. There's not always great solutions. Okay, so that's it. So next week we will just go over what you need to really focus on for the final. So come having looked at that, the study guide, just at least peruse it and have some questions about, and we'll just go through and talk about it so that you feel nice and ready for the final. And then you're done. You're done with me. I think I see you guys in senior clinic. I'll be in there on Fridays. And then that's it. And then you don't have me anymore. I'll miss you. But I will be in there on Friday. So if anyone has Friday clinic, you'll see me.